Welcome back. This is Tiffany and Joe from Buckeye Anti-Aging, and we're diving into some errors that we are seeing in hormone replacement, specifically for men. It seems like something that's coming up a lot more lately, which I'm spending a lot of time answering the phones. So I think that's kind of why I wanted to talk about this a little bit further. Is there is mismanagement, right? The answer more is always better is not really the answer.
Yes. Argue
So
rampant mismanagement.
yes. So we've been getting a lot of calls requesting second opinions, more or less.
Yeah.
So they're being seen by other clinics, and I will not name any of them, but that they're still feeling symptomatic, but it may be in the opposite direction. They
Right.
may not be lethargic anymore, but instead feeling hyper aggressive or disinterested is
Right.
another one that I hear a lot, is that like all of a sudden they don't want to be married to anybody, don't want to have a job, don't want to do anything because fuck everything.
Yeah.
And that's how they're feeling. And when we're seeing those patients, generally what we're running into is mismanagement of some sort.
Right.
Um, so when we're interacting with a patient like this, how is that conversation going when you meet with them? Because
Well,
obviously I'm catching like very surface level, let's get you scheduled. Yes,
yeah.
I think that we should look at your labs. Yes, I think your thyroid could play a part in this. Yes, I like, how does that look?
Well, there's like a subset off of that conversation that becomes multiple conversations. But, um, let's talk about, mismanagement in two ways initially, and that's disregard of other contributory factors and then over replacement, right?
Sure.
Those are the two that we see a lot,
A lot.
right? A lot. Um, the first of which is, let's talk about disregarding other contributory factors,
Sure.
right? I say it all the time. You say it all the time. We tell patients all the time. They don't always listen. Testosterone fixes one thing:
Testosterone.
low testosterone.
Right.
It fixes nothing else, right? It doesn't correct thyroid dysfunction. It doesn't correct adrenal dysfunction. It may mitigate some of the symptoms. It may,
For a time,
it,
maybe.
it may slightly have an influence on the HP axis and reduce cortisol. Ultimately, my opinion is it just because cortisol and testosterone are somewhat antagonistic. It just gives you a dog in the fight. But it doesn't fix that, right? It
Right.
doesn't fix, it has anti-inflammatory properties,
Mm-hmm.
but it doesn't just shut down chronically dysregulated or unmanaged systemic inflammation that's driven by the gut. It doesn't fix methylation imbalance, right? Whether it be MTHFR or COMT. Like it doesn't fix those things. It may acutely blunt some of the symptoms of it because testosterone is powerful and its effects are strong. But it is only corrective intervention for one thing, and that's low testosterone.
Right.
So you have a lot of guys come in, they're like, oh, I'm on TRT and I still feel like shit. And it's like, okay, what about these other 7 things that aren't being addressed? Oh, they didn't mention them.
Right.
Like,
So their lab values could be flawless. They could be treating their testosterone
perfectly. Yes. Right.
and they still could feel like shit.
Right. And then it's, okay, well, if your testosterone is perfect and you're subjectively symptomatic, the problem is not more testosterone, or the fix is not more testosterone. It's what else is going on. And from an endocrine perspective, you look at like thyroid dysfunction, HPA axis or adrenal dysfunction, testosterone dysfunction. So many of those symptoms cross over, right? So many of those symptoms cross over. So you can like broadly attribute a lot of those symptoms to multiple things. And you
Like,
can't.
let's talk about fatigue. That is a number one complaint that I hear.
Yeah.
I mean, how many systems that could that come from?
Yeah.
Like
Virtually all of them.
all of them.
Literally
Yeah, I was
all
gonna
of
say.
them.
Including the one that we don't talk about as much is sleep apnea.
Right. Like I think everybody has.
At
Like,
least
everybody's like,
every adult male over the age of 30.
that's at least 200 pounds, I feel like.
Yeah, 100%.
Really, neck size is a big predictor. I think it's either a 16 and a half or a 17-inch neck. Like if you have that and you're over 35, collagen in your trachea is going to be losing, I don't know, tonality. It's more lax. The weight in your neck, your jaw collapses more and things like that. So
Mhm.
if you snore and you got a 17-inch shirt collar, you got sleep apnea probably.
Of some sort.
I mean, it's like what, like 95%, right?
It's
If you meet that
insane.
criteria, if you meet those criteria.
Yeah.
Yep, I have it. It's the coolest.
There's different things that you can do to manage sleep apnea.
Yeah.
Just so happens you got the neatest one.
Yeah.
My husband, on the other hand, he had obstructive, so he
Yeah.
was able to go get his tonsils and adenoids and his uvula, actually, and his palate shaved back,
Yeah.
and has not had a single symptom since then.
Yeah, I also could probably use my tonsils out and things like that, but I still have a centralized component, so I still get to sleep like a jet pilot,
Darth
like a fighter
Vader.
pilot. Yeah, yeah, which is not only enjoyable but also sexy. So
Jamie loves it.
she does. Yeah, can't keep her hands off me.
All right, anyway,
Yeah,
segued hard.
yeah. Put the mask back on. I mean, just because you can't hear me talk when it's on,
Yes.
me shutting the fuck up is the sexiest thing I could do.
Okay.
So yeah, sleep apnea. So that's the first issue we see.
And honestly, we go down a list in that circumstance. So when somebody is coming into us, their hormones look good from hormone management. That's then where we start checking off, right? We talk about sleep apnea. We talk about their habits throughout the day. How much consumption of caffeine? Do they sleep well? Do they have crash periods? What's their diet look like?
Yeah.
You know, really just run through everything that creates what their day-to-day looks like.
Right. So that's issue number one. And God, we could delve into all of those things and how they matter. There'd be like 4 different podcasts just in those individual topics. So we won't do that now. So we'll leave it at
Coming up next.
Yeah,
No, I'm just kidding.
yeah. We'll leave it at other things make you feel bad too.
Yeah.
The big one that we see, again, I'll never name another practice. There's the list of usual suspects though, is overprescribing.
Yes. Which we're in Columbus, Ohio.
Yeah.
To be clear, I'm sure it's different state to state.
Yeah. A lot of
There's
them
online stuff and,
Yeah.
you know.
Yeah. A lot of them aren't just in Columbus though. So like just gross overprescribing from a dosages perspective.
And why is that? Because you're interacting with offices that will do what the old science says.
Yeah.
You still feel bad? Do more.
Yeah.
Double it.
Yeah.
Do you still feel bad? Okay, do more.
Yeah. Well, and I would say that there's 2 sides to that coin. One, it's the lack of knowledge to expand on what else could be the problem. So it's somebody using the tool that exists in their toolbox. And if you only got one tool, you know what I mean? You're going to
just going to keep hammering at that one.
Yeah, exactly.
Pun intended.
Yeah, I was going to say hammer, 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 hammer. Yeah. Eventually this has got to give. So lack of knowledge, availability, tools to evaluate further. There is another component, and this is me saying as a guy who used to feel the same way. It's easy to fall into the more is better trap.
Because
it is easy to fall in the more is better. Where like
that's a mentality, though,
like,
right? Like
if
some is good, more is better.
If 150 milligrams is cool, 250 is going to be cooler. 300 or 400 or 500 is going to be the best, right?
Yeah.
So like, it's easy. Hey, I don't feel good, doc. My test must be low. Yeah, probably. Let's bump it up 50 milligrams, see how you feel. And where guys run into it is issues with that is overexposure, which causes reduced efficacy to the drug. And then it becomes significantly more difficult to control the side effect profile.
Okay, so let's break down that first part a little bit more. When you over replace, the receptors then get tired.
Yeah.
They get burnt out, essentially.
Yeah. Yeah. They will decline in function and uptake, right? And
so then ultimately what you're taking isn't benefiting you the way it should because it's not received.
Yeah. Drug efficacy reduces, right? Drug efficacy drops. And you can see this in an analogy you'll see because we do some risk management for people that compete, right? In bodybuilding and that. We can't prescribe them, but we'll monitor labs and work on risk management strategies. See, a lot of these guys were like, they started.
And that's the point of it, right?
Yeah.
Risk management.
Right.
We're decreasing the risks.
Right. But you'll see those guys where maybe they started taking their first cycle. They did 250 milligrams a test. And then they decided to blast. And they went up to 500 milligrams. Right. And they were on that long enough to get reduced efficacy to the drug. And then they back their dose down and they're like, oh, I feel like garbage now.
Which you totally do.
Yeah, 250 doesn't do what 250 used to do. So I guess I'm going to stay at 500, right? And now I want to be more aggressive. So then they go to 1,000. All of a sudden, 10 years down the road, this dude, their baseline testosterone dose they take every week is 750 milligrams or 1,000 milligrams, which people take more than that. But they're getting out of this astronomical dosage of a drug what they maybe would have previously got out of a low dose, but they've just smoked receptor response, right?
Which those do have a bounce back. Like it's
Yes.
not like you're shooting them down forever.
Right.
But you're
Right.
gonna feel like shit
Yeah.
for a while
Yeah.
while they recover.
Because you're coupling a reduction of dose with a reduction of efficacy of the drug as a whole, right? So it's a double-fold negative effect, right? So then, you get people where they progressively increase their dose, and for a short window of time, they get an acute resolution of symptoms, right? But then that perpetuates the issues, and then they feel worse again. And in that model, the out only becomes just progressively taking more and more over time all the time, which is not
But
sustainable.
even then, the more isn't even better in that scenario. So it's
Right.
like you push the first time and then it backslides and you push again, but it doesn't go as far. And then backslides and then you push again and it doesn't go as far
Well,
and it backslides.
Yeah, and I
Like,
think a good analogy for that is like insulin resistance, right? Exogenous insulin use, right? You may have somebody that starts off on exogenous insulin. They're already insulin resistant, right? So now they have to take enough exogenous insulin to overcome insulin resistance. So maybe they're taking a Humalog once or twice a day, 25 milligrams. And in 5 years, they're taking 100 milligrams of that exogenous insulin because they've exacerbated insulin resistance with that drug. And that's the only way. Now, we're talking about pancreatic dysfunction and failure here. So it's a little bit different, but it's still endocrine mechanisms, right? And the same can happen, right? Which is why when you look at, I don't want to keep referencing bodybuilding. I'm not trying to give it its flowers or anything, but like the people that are most successful and have longevity in that field are the people that go up minimally as possible and go back off completely, or go to very minimalistic doses and don't run large amounts. Why they live longer, right? And have a better response because they don't have to take enough drugs for a racehorse to be successful, right?
yeah.
Now, that's not what we're doing here. We're doing therapeutic replacement. The point being is the same diminishing response to the drug can exist if you're taking too much, even if it's not an astronomical dose. Right. The other thing, we have to consider with testosterone is, what it regulates. It influences neurochemistry. It influences serotonin and dopamine in the prefrontal cortex. Allopregnanolone downstream, which can form from metabolites thereof, influences GABA, right? So it does have influences on mood and things very aggressively. And when dosed appropriately, balances those things very well. When overloaded, does not balance these things so well, right? So it's like you can take too much. That's why we hear a lot of people like, oh, I don't want TRT to make me angry and rage. And it's like, well, if it's done right, it shouldn't. In fact, I find myself to be significantly calmer and nicer.
Yeah, I was going to say, because low testosterone can also make you irritable and angry.
Oh, felt awful. Not on testosterone, right? So when managed and balanced appropriately can really stabilize a lot of those symptoms, but you can overdo it. And the consequence of that is the opposite of the therapeutic effects you want, right? So, why does that happen so much? I would say it's the lack of availability of tools and people doing that. It's also because it'll make you shut the fuck up and keep giving them your money. And that sounds very bleak. And maybe that sounds pessimistic on my part. But oh yeah, we'll bump your dose is a 5-minute conversation. Hey, your levels look great, something else is going on. That's like a 45-minute conversation.
That's true.
Right?
That is true.
Especially if you have a patient who is pre-inclined to want testosterone to be the problem.
Yeah.
Right?
Yeah.
Which is a very real thing.
And I mean, you run the risk of losing a patient if you have that conversation and they don't like it. I mean, that just is what it is.
For sure. And we've lost patients because of that.
Yeah.
Yeah. And
education is our goal. We want you to know.
Yep. And that's fine. And then usually in 6 to 12 months, they come back and they're like, yeah, you were right. I did more and I don't feel better. Okay. Like, that's fine. And we're open to that. Everybody goes through their own learning process and curve. I said, I have been guilty of that own thought process where like, this will definitely fix anything. And if anybody knows better, it's me. It's what I do for a living. Right. So I should know better, but I don't know. The meathead in me just doesn't want to go away.
The dude just was like, I have to know. More is better.
Yeah. There's still a caveman banging rocks together somewhere in my brain that wants to run the show. So, so I would say that's not really like, if the patient has been misled initially, it's not their fault to have those preconceived notions.
Yeah.
Right.
And also it feels like a simpler answer, right?
It is a simpler answer.
I mean, it is,
It is.
especially when you start diving into the concept of management of adrenals and things like that. That does require you to change your lifestyle.
Well, it's almost exclusively what it requires. Really,
And some people are not interested in that.
no, they're not, and it's a pain in the butt, and that's what, you and I have both gone through it,
Mhm.
and it is labor. That, God, I get up at 6 o'clock in the every morning and meditate for 30 minutes, which is not something I ever thought I'd do, and don't drink caffeine, and
I go to bed at 9 p.m. on the
yeah,
weekends because it's easier for me to do that than to try to mess something up for the next 6 weeks because I stayed out until midnight. Like,
yeah, yeah, no caffeine, no alcohol, two things that I greatly enjoyed,
caffeine is the
it
best.
is, you know, uh, going to bed earlier, turning the TV off, we changed how we train, like
I
all of
mean,
those.
going out and touching grass, like
Yeah,
people would make jokes about that, but like being outside and getting the sunlight in the morning, like a big deal.
yeah. Or one more, they touch grass and slap them. But
Kids say that.
my kids, yeah,
I was
go
gonna say,
touch
I'm so
yeah,
cool.
yeah, go touch grass, you nerd. Yeah, go touch grass. I have a 12-year-old. So it's yeah,
She
but
knows some stuff about adrenals.
she knows how to ruin them. Um, but so does he. But yeah, I mean, it requires more care. But
In the long term, it's going to be so much more beneficial for you than chasing what you think
chasing a
is.
number,
Yeah.
and you see it. You have guys come in where they're like, I feel like trash. My TRT is not working. And 3 days post injection, their total test is like 2,300. And they're like, no way it's that high. Your lab must be wrong. I'm like, no, it's accurate.
That
Like
is a
all,
conversation that I have on 1 month blood works all the time. So
like,
starting on care and then their labs are looking, I mean, Dr. Bainan is fairly spot on. Like we don't have to make much modifications after 1 or 2 lab draws.
yeah,
And then they're like, no way do they look like this. Like, well, how do they look like that? And I'm like, because that's what it did. We replaced testosterone.
yeah. And it's like,
Like,
yeah, it's like, we are not LabCorp. We have no stake in the game. You know what I mean?
yeah.
And I think people also overestimate what replacement therapy is. That's all the bro science online of like, there is no magic number of testosterone that is right for every person.
Well, and it's specific to you.
Yeah, where you hear people online like, well, I heard online like 250 weeks a normal replacement dose. And it's like painting with a pretty broad brush. But realistically speaking, I would say I see most patients from an actual replacement standpoint, optimized care, free testosterone in the upper quartile, fall somewhere between 100 and 200 milligrams a week I would say that's the average range, with the mean running probably somewhere in that like 130 to 160 range.
Yeah, and it's not the argument that everybody should be on 200 milligrams a week.
Right.
Like that's not a number
That's not how that works.
that's not how that works.
Right.
Everybody metabolizes different. Everybody experiences that hormone differently.
Right. And it's, I would say in 15 years and seeing thousands and thousands of male patients, I could count on one hand the number of patients that their true replacement dose exceeds like 220 milligrams a week.
I'm thinking in my head right now, and I think that we have maybe 3
Maybe 3. And
out of like 900.
yeah, and I'm combining my 5 with almost a decade at another practice.
Yeah.
Right? It's extremely uncommon.
But it's how they metabolize it, how they use that medication.
Correct. Right? Yeah. So people run into TRT, and then you have to worry, the larger the dose, it becomes harder to control the aromatization profile. Right.
Which is a whole other thing.
Right. So when you look at some of
That's
these
in the
patients,
mismanagement category.
yeah, because we generally look at splitting doses up,
Mhm.
like, kind of at a minimum, at least twice a week. And that's really on a matter of patient preference. But the more frequent the administration, the more stable your dose.
But in reality, we're talking about compliance here. So if you're missing doses, even if you are supposed to be splitting it, you're messing with your experience far more than if you just do it once weekly, if you could do that correctly.
Yeah. So it's like, yeah. So it's one of those things where like we have patients that do 3, 5, 7 times a week.
Yeah.
Which is great if you'll take it. But if it's like you're supposed to do it 3 days a week and you get one and you're doing a third of the dose once a week, like that doesn't work.
No.
That doesn't work. In fact, all you've done is neuroendocrine suppress yourself so much and then not replaced it,
Yeah.
right? So it is based on patient. So yes, there is the more frequent the administration, the closer to natural physiology, the lower the aromatization profile because of the lower the transient spikes, if you'll do it.
Correct.
So there's individual adjustments that have to go into that where we're dealing with what is most beneficial relative to what we can actually get the patient to do,
Right.
right? But you look at, we had a patient that came in that was, 300 mgs once a week, okay? His 1 to 3 day post-injection peak is going to be so transiently huge that the aromatization profile is going to be extraordinarily difficult to sustain or control.
Because let's talk about it. When you replace testosterone, testosterone also converts into estrogen. So
Right.
as testosterone is coming up, estrogen, based on how you aromatize, is also coming with it.
Yes. But it'll store in adipocytes, fat cells, and it will clear a little slower, right?
Mhm.
So you can get a cumulative effect even if your testosterone's no longer climbing, right?
Which is neat.
Right. But so you do that, and then you worry about stimulus of erythropoiesis, right? So EPO production and bone marrow activity, those big transient spikes hit harder too. So
Mhm.
not only are we getting to the point where your testosterone is on a roller coaster, your dose is generally overdosed, but the relative side effect profile you have to worry about with testosterone from the aromatase profile and blood thickening like becomes significantly harder to control, right?
Yeah.
So, when I'm talking to patients and we're doing day twos, I always advise to break their doses up into smaller doses in the magnitude that they're comfortable with, like as far as dosing frequency,
Yeah.
right? God, I don't think we have hardly anybody that does the old school once a week anymore.
Some of our older fellas,
That just,
it's just convenient. You
it's
know what
just
I
convenient.
mean?
Yeah. So,
And the other concern is that if estrogen isn't managed, so in the mismanagement category, you are experiencing other things besides the elevated hemoglobin and hematocrit. You're also seeing concerns with mood. You can also run into things like gyno,
weight gain,
weight
water
gain,
retention, ED, all sorts of
ED,
things,
big one.
which that's a fun one because too much or too little estrogen can both universally make your penis not work, right?
Yeah. So you always have to consider what your baseline is.
Yeah. So there's multiple factors that go into that. The other thing I see is maintenance agents for maintaining testicular function that will not work with testosterone.
Ooh, Clomid.
Clomid is a big one, right? So when we understand pharmacokinetics, pharmacodynamics, like what drugs do, Clomid is a SERM. It's a selective estrogen receptor modulator. How it keeps the testicles active is by blocking estrogen receptors, right,
Hmm.
at the hypothalamic level and pituitary level to make them think that you are completely absent of estrogen, and therefore GnRH will drive LH and FSH. So your gonadotropic hormones go up and stimulate the testes. Okay,
Sure.
will work as a monotherapy. However,
So working by
itself,
itself.
estrogen and testosterone do not have the same receptors. So if you take therapeutic replacement and you push your testosterone high enough, which you will still get negative feedback from your androgens.
Hmm.
And your LH and FSH will still shut down. And this is not theoretically, we see it. People come in, oh, I do this and I take Clomid. Well, your LH and FSH is still undetectable. So the Clomid is doing nothing. And based on how the drug works, it would make sense. And for me, I'm like, that's gimmicky.
And
Right?
also, Clomid is not absent of side effects.
No.
So
No.
you consistently taking it, you may actually be having a worse time than a better time because of the side effects itself.
I felt like trash on Clomid. So, we see a lot of that where it's like, oh, they gave me this drug to keep my testicles active. And it's like,
It can if you cycle off your testosterone.
yeah, but that's with testosterone, efficacy is like non-existent. So then you're getting more into your GnRH analogs or things that act like that, like your kispeptins, your gonadorelins, or your ones that replace LH and FSH, HCG, HMG, although HCG is about 90% analogous to LH. So it's better for testosterone than sperm, really. Things that can't be rendered ineffective by negative feedback communication from testosterone,
Right.
right? So it's knowing what drugs are being used in combination and whether or not that makes sense,
Right.
right? And whether or not they work. Third thing I would say, so it's the frequency of dosing, the volume of dosing, the prescribing of drugs that render each other ineffective. God, what other ones do we see? They're pretty common. I just had one and it just floated away from my brain on me. The constant use of DIM to control estrogen.
Oh my God, that is a button for me.
Yeah, everyone.
Dim.
Yes. So I would say we are neither staunchly for or staunchly against the use of aromatase inhibitors. Would you say that's fair?
That's fair.
Right.
We attempt to mitigate as much as humanly possible independent of medication.
Yes. Because we understand that there is no such thing of a risk-free drug. And we understand that there is a side effect of having no estrogen. You don't want to have no estrogen. And we can do all the things in the world to mitigate aromatization. The most obvious one is increasing the frequency and reducing the volume of doses, right? Smaller amounts more frequently to minimize transient peaks. And we try to do that. Some people still get out of control with their aromatase profile because of body composition and things like that. And in that case, yeah, is it better to have somebody on an AI than letting a man's estradiol be 90?
1000%.
Yes, probably. Yeah, as long as it's within like appropriate dosing. So I'm not going to take the hard stance for or against AIs. Just that you understand how to use them, right? Is what matters. Everybody in the freaking world uses DIM. Okay. Nobody
because
knows.
they think that it's slowing the aromatization profile, on which it is not.
It is not. So DIM specifically inhibits the formation of your 16-hydroxy estrogen metabolites,
which is a downstream metabolite, not
Right.
estrone, estradiol, or estriol.
Yes.
It's a downstream.
Yeah, right. So it's inhibiting the enzyme that causes your most estrogenic metabolites to form, right? That cause bloating and water retention and mood, which is great if that's your problem.
Right.
If that's your problem. Like nobody tests if that's the problem though.
No, definitely
Nobody tests
not.
if that's a problem.
It's Arctic in here, which is why I keep touching my nose.
Yeah.
By the way.
Yeah. You got some of that Bolivian Martian powder on there? What did you do before the podcast? Yep.
So, and the other concern is that if they're aromatizing so significantly, DIM isn't going to be beneficial, whether or not that is their problem.
It's not going to stay. It's not going to overcome that, right?
Correct. Yeah.
And it also works through regulating hepatic liver enzymes that influence hormone metabolism, which are also pretty aggressively involved in drug metabolism. So supplements are not just these like harmless, innocuous things that you don't need to know like what you're taking them with, right? So when we start getting into supplements that may or may not regulate different pathways of what the liver does in regards to hormone metabolism, it also may modify pathways of metabolism of drugs that are in your system, right? So you may need to know, like, can I take this with this medication that I'm on, right? Or this medication or this medication.
And I mean, let's think about how many other medications you would say on average a male patient that we have is on over the age of 45.
Over the age of 40, I bet each of them have at least a handful.
I mean, at least 2 or 3 off of the top of my head.
Right. Well, you look at like the CYP3A4 enzyme, right, that influences the conversion of estradiol to estriol and estrone to 16-hydroxyestrone. It's like 50% of all drugs are metabolized down that pathway, at least partially.
Yeah.
Right. So how much are we like unknowingly out of need, or we don't know, but like we're manipulating these different enzymes that may influence other stuff that we take, right? And that matters too.
That does matter.
Right. And again, just like I'm not staunchly for or against aromatase inhibitors, I'm not staunchly against or for or against DIM either. It's just,
I mean, we have patients who use DIM.
we have plenty of patients that use DIM.
I mean, not plenty, but handful of patients
but
who have clinical reasoning on why they use DIM.
Because we've tested it and we know specifically this specific pathway is problematic for you.
Yes.
Right. And in that case, you could also look at like using a calcium D-glucarate in lieu if you really felt so. Because if you really didn't want to take an AI, what you would do is you would optimize all the downstream pathways of the liver's clearance of estrogen to at least kick it out faster. So you'd support glucuronidase clearance, you'd support glutathione clearance, you'd support methylation, right? So then
Which is a whole other can of worms to talk
right.
about.
So then it's like, okay, we're going to take calcium D-glucarate and you're going to take N-acetylcysteine, glutamine, and glycine so you can make glutathione. You're going to do methylation cofactors like S-adenomethionine and B vitamins and magnesium and all
But
this
you need to
shit.
know which ones are right for you.
Right, right. Unless you want to just blindly hammer all of them.
Yeah.
But even like even when it comes to like methylation, which we got to find out on me, like COMT enzyme activity influences catechol-estrogen, but also things like catechols like dopamine, epinephrine, and norepinephrine, where like you don't want to necessarily be heavy-handed with that COMT enzyme with the wrong things, right? So, or you can make things worse, not better. So it's
especially when it comes to like emotional response and things like that.
Yeah. So that's where we look at. Shut up. That's where we look at. You know, diagnostics matter.
They
right?
matter.
To just not like blindly throw. And I would say we generally have gotten a point as a practice. We don't even recommend supplements without a diagnostic supporting evidence too. Now there are some things that you can take that are like inconsequential for the most part. Like,
or like if your liver enzymes are elevated for 2 labs, we may just consider 1 cycle of NAC or something like that.
NAC or glutathione patches or something.
Something.
Like that's like that's probably not. It's not going to hurt you. Like upregulating your master antioxidant is not going to hurt you.
No.
Right. Only good things. You could probably take omega-3s and they're not going to hurt you. Right. Like things like that exist. But when we're getting more into like messing with kind of, if you want to call it like the organic chemistry of the body, like you don't just blindly throw handfuls of stuff at that either.
Yeah.
Right.
Yeah. Because the theory that you just pee all the things you don't need out isn't necessarily accurate.
No.
Although somewhat accurate.
Somewhat accurate, yeah, but not necessarily. Right?
Yeah.
So
yeah.
So yeah, like all of those things have benefits and consequences, but it's just kind of like we talked about in the last podcast with women. Individualization of care super matters for it to be done the right way.
Yes.
Right. You need guidance and you need somebody that knows what they're doing. And I would say somebody that is willing to take time to look at your shit
and
figure out
it.
Yeah, explain it and explain what's going on.
And listen to you.
Yep. And I think that's the stance that we've taken. Like, we're going to do things the right way. Right. Even if it means that sometimes the answer you get is not the answer that you want, but it's the right answer for you, and we're being more proactive in your healthcare. Like, we have a ton of patients on testosterone. It's a huge part of our business, but we're never the group that's just like, yeah, we'll just blindly throw you on some stuff. Like, come do some labs in a year, take your 200 or 250 a week, and
we'll see you when we see you. Yeah.
You know, which is some people's business model. Which is a bad model.
Which we just don't agree with.
Which is a bad model, right? So that's what we see most commonly.
Yeah.